I'm going to discuss the PopART trial, and in contrast to the previous speaker, I do know the results. And I also know that some of you know the results, and I hope by the end of this session you will all know the results. So just to reiterate, the PopART trial was designed to see if a combination HIV prevention package that was delivered to the whole community, if that can, universal testing and treatment, if that can reduce the HIV incidence at population level. And the final results were known in March 2019 and were presented by the principal investigator, Professor Richard Hayes, at CROI 2 months ago. I have nothing to disclose. So this is an overview of the presentation. I will have 2 slides on what the HPTN is and does, something about the study background, why we did this study, an overview of the design, the study findings. We'll pay some attention to the aspects of community engagement and some final contemplations. So what is the HPTN? The HPTN stands for the HIV Prevention Trials Network, and that's a collaboration of many scientists and researchers all over the world, and many partners and communities collaborate in it. They do many studies, and the focus of the HPTN is to look if we can find effective interventions to reduce the acquisition and transmission of HIV. Now, what's the philosophy of the HPTN? Well, first of all, the HPTN believes that there is no silver bullet or one-size-fits-all intervention that is good for all, but we have to look at combinations of strategies. And these combinations of strategies needs to be tailored to the populations that we're focusing on. And the HPTN focuses on vulnerable populations, and you see some examples here: adolescents, men that have sex with men, women, transgender people, substance users, and less well-off communities. So a combination of interventions, especially in the absence of an effective vaccine. So what's the study background? I can be short here. We know that the HIV incidence in Southern Africa is still high, and we want to get that as close to zero as possible, obviously. Another more practical consequence of this high incidence is that the population of HIV-positive people will grow due to effective treatment, and this will be a higher burden on the healthcare resources. So why was PopART conducted? Well, first of all, we built upon scientific evidence that early treatment, early ART treatment is beneficial, has good health outcomes, and reduces the transmission of HIV to the sexual partner, the HIV-negative sexual partner. We've seen that in the HPTN 052 trial. In discordant couples, we see that the transmission to the HIV-negative partner goes down to zero if the HIV-positive partner is on effective treatment. So it's our mathematical modelers that have shown that in the communities that we aim to work in, that a combination of different interventions, male circumcision, prevention of mother-to-child transmission, behavioral interventions, and expanded HIV testing, that this combination of interventions can reduce the HIV transmission in a community by 30 to 50%. So that was the basis of our trial. So the objective was, and I'm going to read it out with you, is to find out how well a combination prevention package that includes home-based HIV testing and linkage to HIV care works to reduce number of new cases in large communities, and whether it's possible and affordable to deliver. So a study overview. We worked in this cluster randomized trial, It's a cluster randomized trial means that we don't assign an intervention to an individual, but a whole cluster. That means everybody who lives in one community receives the intervention. We worked in 21 communities, 9 in South Africa and 12 in Zambia. And if you look at the maps, then the communities in Zambia, the northern and the southern community, are about 800 kilometers apart. And the 9 communities in South Africa were all in Western Cape, and they were like 80 kilometers apart. So it's a population level study. That means all the people in a community, the whole population, is exposed to the intervention. This is the design of the trial, 21 communities and 3 arms. 7 communities were placed in Arm A, and Arm A got the full PopART intervention, and I'll explain that later. And one component of it is that they got immediate ART irrespective of CD4 counts. 7 communities in Arm B, they also got the full PopART intervention, but then initiation according to national guidelines. Arm C was our control arm, also 7 communities, and there was no intervention, but standard of care was applied. That means everybody who lived in the community could go to the clinic, could get tested, or go to other partners that were already present in those communities. Oops. It was a matched trial. That means we worked in 7 triplets, so the communities were also organized in triplets, and every triplet had 1 community in Arm A, 1 community in Arm B, and 1 community in Arm C. And those triplets were balanced on geographic location and on HIV prevalence and the size of the communities. So a matched design. And this is the intervention in more detail. If we go to the right side of the slide, we see the components of the intervention package. It contained universal HIV counseling and testing. For those HIV negative males that were not yet circumcised, we referred for male circumcision. For HIV positive mothers, pregnant women, we referred them for PMTCT. STI screening was done based on symptoms, and someone who has positive symptoms on one of the STIs could be referred to the clinic. We did TB screening based on 4 symptoms. Someone who was symptomatic on 1 symptom was asked to submit sputum, and the sputum was brought to the clinic and examined for TB. We also promoted the use of condoms and distributed lots of condoms in the community and the households. So that's the package. How was it delivered? What were the field logistics and procedures? And then we go to the left side of the slide, and we see on top, we see the people that deliver the intervention. We call them lay counselors, and we gave them the abbreviation CHIPS, and CHIPS stands for Community HIV Care Providers. They worked in pairs, and a pair of CHIPS was responsible for 450 to 500 households in a zone, a CHIPS zone. So they delivered the HIV prevention package door to door in their zone. If they went to a household and not everybody was at home at the first visit, they did repeated visits to make sure that everybody is at least met once face to face. They delivered the package, and then people who needed to be referred for appropriate care were referred to the local health center. So there were no separate research health centers, but we used the local governmental health center. And after referral, the CHIPS went back to the people they referred to see if they actually went to the clinic. And if they went to the clinic, they check if the person were doing well or not. If they didn't go to the clinic, they did additional counseling to make sure that they were more willing to go to the clinic. So this intervention was delivered in 3 annual rounds. That means the CHIPS covered their zone in 3 annual rounds. Now the trial population, the total population of all these communities together was like 1 million. That means that if we look at the arm A and B, the population of those where we delivered the intervention was like 600,000 people. So it was really a big study. The average population of one community was like 50,000. Now, how do we know if this intervention works to reduce HIV incidence? For that, we did a sample. We sampled every community, and we took a sample of 2,500 adults. And that means we had a total of 52,000 in the study. They were aged 18 to 44 years. And after enrollment, we followed them up for 12 months, 24 months, and 36 months. At every visit, a blood sample was taken, and it was tested for HIV at our local lab in Zambia or South Africa, and also by the network lab of the HPTN. What are we analyzing, or what have we analyzed? We want to compare the incidence in the communities of Arm A and compare them to our control communities in Arm C. And similarly, we're going to compare the HIV incidence in Arm B with the incidence in Arm C. Secondary objective was to look at viral suppression, and just like for the HIV incidence, we also compared here the viral suppression in arms A with arm C and arms B with arm C, and viral suppression was defined as less than 400 copies per milliliter blood. This is the timeline of the study. We started in 2013 and we ended in 2018, halfway 2018. If we look at the CHIPS intervention, this was done in 3 annual rounds over 4 years. We look at the population cohort, the measurement of the HIV incidence. We did 4 surveys, and we had an analysis period, a predefined analysis period of 12 months to 36 months. And this was done with the idea that it takes like 12 months or at least a year for the intervention to kick in. The ART eligibility criteria changed over time during the study. So in the arm A communities, part of the intervention package from the start was immediate ART. So that was throughout the study, immediate ART was offered at the HIV positive participants in the arm A communities. In the arm B and arm C communities, it changed over time. It started with CD4 counts less than 350. It changed to 500. And halfway the study, all the communities had immediate ART. So in this sense, the arm B communities and arm A communities are very similar because they offer immediate treatment in all the intervention communities. The results, just to give you an impression of the scale of the work, in South Africa, in the last round of the intervention, we visited 56,000 households and 77,000 adults were consenting to participate in the intervention. We had around 100,000 households in Zambia with 181,000 consenting to the intervention, and that was only the last round of the intervention. Here we see if the implementation of the intervention was successful. So this is intervention data only. We look at the first 90. Let me focus on the left graph for arm A. We see the first 90, and I'm struggling to see the numbers. Sorry for this. So for the first 90, we see that before the study, let me first explain that the orange bars are the ones at the beginning of the trial, and the blue bars are at the end of the trial. So we see that like 55% of the HIV positive populations know their status at the beginning of the trial, and it goes up to 90% at the end of the trial. For the second 90, we see it increases from 80 to 90%, so 80% of the HIV positives that know their status are on treatment at the beginning of the trial, going up to 90%. And if you combine the two, you get ART coverage, and we see that increases from 45% to 82%, so reaching the first 90, the first to 90. For arm B, that's very similar, so I'm not going to go through those numbers. If we express this in another graph, we can see here that overall we've reached the first 90. If the first 90, because 90 times 90 is 81, so 81% is overall, we've reached the first 90 in arm A and arm B. However, if you split it up per age group, we see that we still fall short in the younger ages and especially in the men. So there we don't reach the first 81%, but we do so in the older age groups. Then that's the intervention data. Let's look at the population cohort. We want our data to be, our arms to be balanced. So we look at the balance. We have 12,000 cohort participants in arm A, 13,000 in arm B, and 12,000 in arm C. We see that we have had problems recruiting males. Like 30% were males, 70% were females. And that's simply because the males were not at home. Even after repeated visits, we didn't reach them. We have a relatively young cohort. We see here in the blue, that's the 18 to 24-year-olds. That's like 40%. We see there in the red segments, we see the 25 to 34 years old, and the green ones are the older ones. So it's a relatively young cohort, but it's well balanced across the arms. HIV prevalence is like 21% in arm A, B, and C. we see that the HIV prevalence in females is twice as high as in males. And here the ART coverage at the beginning of the population cohort was like 31%, 32% in arm C and 38% in arm B. Now, what has this intervention meant for the incidence? So if we look at the right graph to start with, on the y-axis we see the HIV incidence, and on the x-axis we see the communities in arm B and arm C. So if we look at the arm C communities, we see it ranges from 2.5% to most communities are above 1%, and one community is below 1%. These HIV prevalences, HIV incidences are still very high. That's something to take note of. What we see in the colored connected lines are the triplets. So within each triplet between arm B and C, we see a reduction in HIV incidence. And that is systematically in all 7 triplets. And that is quite a remarkable, for a community randomized trial, that's quite a remarkable result to see such a structural decline in incidence. So we were happy with that. However, if we look at the arms A communities compared to arm C, we see that's a mixed picture. We see 4 of the 7 triplets, we see a decline in HIV incidence, but in 3 of them we don't. We see that the arm A communities are higher. This was a surprising result, and we'll get back to that. If we express this in numbers, we see in the arm C communities, overall the incidence was 1.55%, and it declined in arm C to 1.06%. That means a 30% reduction. We find a low p-value. That means we have strong evidence that the HIV prevention package made a difference in terms of incidence in arm B. And like we've seen in the graph, we see a very small reduction in arm A communities, 7%, and no statistical significance for that. If we look at the subgroups, HIV incidence, and we compare arm B, the red bars, with arm C, the blue ones, we see that in men, the HIV incidence reduced by 50% in arm B, lesser reduction in women, where it goes from 2% to 1.4%, also lesser reduction in young people, and more reduction in older people. How about viral load? Viral load suppression, arm C communities, we see 63% of the HIV positive participants are virally suppressed. It's higher in arm B and even higher in arm C, 72%. So again, in arm A, we seem to have reached the 90-90-90 targets, because 90 times 90 times 90 will be a bit more than 70%. We see a 16% increase in arm A compared to arm C, with borderline significance, a p-value of 0.07. Now, so far this was a quantitative look at the trial. We talked about numbers and trial design. We also need to focus on community engagement, a more qualitative aspect of the study. So we were present with many different staff members in the communities. We had like 650 chips. We had about 100 enumerators doing the population cohort. We had research nurses, we had drivers. And it was in the last picture on the bottom right side, you see the social scientists. They have been very instrumental in building up a relationship with these communities. They were very important. So what happened? Before we started the trial, they did a stakeholder analysis to see what type of organizations, what type of institutions, etc., were present in each community. Every community is different, they're not homogeneous, so they were studying every community. And they set up adults, what we call community advisory boards. Those community advisory boards, they had representatives from the community. They were well-respected people. It's religious leaders, traditional leaders, teachers, etc. So also members from the adolescent CAPs were present, so young people representing the adolescents. Neighborhood health committee, those were volunteers who worked in the clinics, from the clinics, were present. And those community advisory boards They were our way of communicating to the community and also getting feedback from the community. So we built up a relationship with those communities to make sure that we are welcome in the communities and that we can do our work and get feedback from the communities. So it's a matter of building up trust and respect. So to give you an example of how they helped us, community representatives, they participated in the randomization, the public randomization ceremony that we had at the beginning of the trial. So we were having some kind of lottery or whatever to by chance allocate a community to an intervention, and it was the people from the Community Advisory Board who helped us with that to make our process transparent. They also supported us with recruitment. As I said, we struggled, for instance, with finding men, and they gave us alternatives to be able to reach the man. For instance, they draw our attention to workplaces where we could find men and give them the same intervention as we would otherwise deliver it in the homes. They also helped us with setting up man-up campaigns, often a 1 or 2 day event done at a football pitch where men were offered all kinds of health services like blood pressure, dental health services, eye checking, etc. That was important for us to engage with them and to look at alternatives, and they varied per community. Also, the RMC communities, they're equally important for our trial, and sometimes the control communities might feel left out, so also the CAPs helped us with engaging with the RMC communities. I see that I have to hurry up. Now, it's not only getting access to the communities and building up a relationship, it's also about saying goodbye to the communities. So also the community advisory boards helped us with our exit. We all know about the Brexit. We also had a kind of an exit. And for instance, all these chips that were working for us, they were living in the communities themselves, often. Most of them are residents in the communities. So we wanted to have them, an alternative when the trial stops. So we were giving them trainings on how to write a CV. We were also looking for other partners in the community so that it could maybe get a job at on another project. Also, we didn't pull out immediately from those communities. It's not like on the 31st of December 2017 that all the chips stopped working. We had like 25% of the chips remained in the community for like 6-7 months, and they gave services not door to door, but from the hubs. So if someone wanted to have access to health services, they could go to the hubs. Also, we prepared the community members for the dissemination of the results. It's not like if we have the dissemination of the results to the communities, it's not like one person is talking to them about the results, but it's often a participatory approach where, the first we do some dancing, singing, etc. I still have 2 minutes, I see. And in this participatory approach, we focus on the communities that people come from and not the overall design. And we ask them questions, well, what does it mean for your community that HIV incidence is still high? Or what does it mean for your community? What do you think is important if you see that the HIV incidence reduction in men is higher than in women? So their opinion was asked, and that was an important part of the exit process. I'm sorry, it doesn't work. Final thoughts, and I'm gonna speed up a bit. We've seen that PopART achieved the first two UNAIDS 1990 targets. That means high rate of HIV testing, high rates of linkage to HIV care in both arm A's and B. We have high rates of viral suppression. We managed to reduce HIV incidence by 30%, and we think that's a good result. If we compare that to other UTT trials, there were 3 other ones, then we see that the SEARCH and the TASP trial did not find an impact on HIV incidence. The BCPP, the Botswana Combination Prevention Project, did find a reduction with, I think, borderline significance. We did find no effect. We didn't find an effect in the arm A communities compared to arm C. And this was surprising. And we probably have another couple of months or maybe years of work to see if we understand why this didn't have an impact. And we can think of, we can speculate on what the reason is. One could be that we didn't deliver the intervention well in some of the communities. We don't have any evidence for that. If we look at our numbers for coverage of the intervention, the uptake of testing, they're equally good in arm A as arm B. So we don't have any evidence for that. Could it be chance? Could it be that the intervention didn't work in 3 of the total 14 communities? That would be possible. It could also be chance that it's the way we sampled our data, that the sampling of the population cohort by chance didn't see a decline in incidence while it was there. Could it be the messaging? One of the messagings that could have been misunderstood is that we are in arm A communities. There could be, people could think, well, everybody's on treatment and the chance for transmission is reduced, so that could have a result in sexual disinhibition, meaning people engaging in more riskier sex. Also for that, we don't have any evidence. In the population cohort, we do ask questions about sexual behavior, and we don't see a change in sexual behavior over time. We are currently doing HSV testing in the blood samples we have to see if we can find some evidence of differences in sexual behavior between the arms. Or could it be the sexual networks? And the sexual networks would mean that it could be that the new incident cases are not from within the community where we deliver the intervention, but could be from outside the community where we didn't deliver the intervention. And maybe phylogenetics can help us with that together with the qualitative research. I'm going to skip some slides and I'm going to show you the last one. So what we want to do is we want to look at the HIV sequencing of the samples that we have in our population cohort. And we think that if you look at the HIV sequences, you could identify clusters. And clusters are, in the HIV dynamics and transmission, those could be related. That means if we see clusters, it could be that one infected the other or the other way around. It can also be that we see isolated HIV sequences. And those can be coming from outside the community. So it's this dynamics, that they're very complex dynamics, but we hope that the phylogenetics can give us an answer on that. Is that 2 minutes after I'm over time, or? Oh, okay, I'm sorry. Thank you very much. I'm going to end with a slide. Oh, it's already gone. With thanking the communities because they were really instrumental. Thank you. Thank you.